Now it's my pleasure to introduce another colleague who's had an effect on my life, and that's our keynote speaker, Dr. Jan Jones-Schenk, Executive Dean Emeritus of the Michael O. Levitt School of Health at Western Governors University, for her address on competency-based education. Things for the journey, what nurse educators know. The Levitt School of Health is entirely competency-based and offers graduate and undergraduate degrees in nursing and the health professions. During her tenure, Dr. Jones-Schenk facilitated over 95,000 graduates. She was also the architect of the Institute for Advancing Health Value, including the design of certificates for value-based care and population health equity. Dr. Jones-Schenk, Jan as I call her, has served on the boards of the American Nurses Association, Park City Hospital, Association for Leadership Science in Nursing, and National Education Progression in Nursing, and Aquifer, a medical education technology company. She is also the past president of the ANCC, the American Nurses Credentialing Center. Jan is a fellow of the Academy of Associate Degree Nursing and a fellow of the American Academy of Nursing. In 2022, she too was honored by the NLN with the prestigious President's Award for Innovation in Nursing Education. She is associate editor for the monthly leadership column for the Journal of Continuing Education in Nursing. Colleagues, please join me in giving a warm welcome to Dr. Jan Jones-Schenk.
Wow, there's a lot of you out here. I hear around 1,300. Simulation and competency-based education are the two most powerful innovations in nursing education in the past 15 years. In point of fact, it was 15 years ago I was at this meeting in a simulation session discussing how we were implementing simulation as an assessment tool for CBE. The gasps from the audience were audible. At that time, there were very strong feelings about how simulation could and should be used, and assessment was not one of them. Colleagues and friends, we've had some problems in nursing education. For the last several years, our colleagues in practice have been raising the alarm that there's a gap between our perceptions of student preparation at graduation and what they see in new graduate practice. More recently, we've come to realize that our established practices for admission, testing, and even teaching contain structural barriers, including racism and cultural and linguistic barriers, that have prevented us from educating a diverse nursing workforce to serve our increasingly culturally and ethnically diverse populations. We've seen growth in health disparities, increases in maternal mortality. We're experiencing a growing faculty shortage with insufficient salaries, growing dissatisfaction, declining full-time faculty positions. Clinical teaching roles are the most undervalued and thus the most difficult to fill. On the plus side, we've seen solutions in the form of increased research on the efficacy of simulation for clinical education and the expansion of its use. The development of nursing residencies has responded to the challenges of the increased complexity of roles for new nurses entering practice. changes in admission criteria, and a more investigative approach to rooting out implicit bias in teaching and learning and assessment of students is gaining traction. The licensure exam has refocused its attention for the evaluation of clinical decision-making as its core emphasis. And while these are all welcome changes that are addressing known challenges, the actual evolution of teaching and learning is largely unchanged in nursing education practice. Now's the time for those of us who lead in the facilitation of learning to demonstrate our commitment to transforming our practice using new methods for learning and assessing learning. Actually, truth be told, competency-based education, or CBE, is not new to nursing. Our history in nursing education has always been tied to competency. Preparing nurses for practice has been our long-standing social pledge. But along the way, some things got reframed in ways that diverted us from this essential core. As we focus more on curricular content, we focus less on knowledge, skills, and abilities essential for the formation of competent practitioners. As a practice profession, we value the thinking in practice and the variations of the human experience that present in unexpected and unpredictable ways. We've begun to see that we need to flip our focus with increased attention on learner skills and competency, in some ways returning to our roots, where competency in practice was our long-held core. The National League for Nursing, as a leader in nursing education, led in this early dialogue when they transformed the standards for nurse educators articulated in their 2016 nursing education standards. Soon after that, the National Council of State Boards of Nursing began its efforts to transform measurements for nurse licensure. In 2019, the American Association of Colleges of Nursing issued their new vision for a transition to competency-based education for all nursing programs within 5 years. Earlier this year, and I had the pleasure to serve with this group, the NLN published its strategic vision for competency-based education. Here's the summary of that vision. It's kind of long, so bear with me. CBE holds promise for being able to lift and shift education beyond traditions of credit hours, clinical hours, and grades to a new, more fluid future of confident, competent, new graduate nurses at all levels of entry and practice who will feel prepared and be prepared to persist in high-quality nursing practice across their careers. That's a lot of information in a big, long sentence, so let's unpack it a little bit, see what it means. The first part takes on some long-standing academic traditions that might make for some audible gasps here today. Credit hours, clinical hours, and grades are long-standing conventions of academic nursing education. The credit hour came to us from early work to establish a Carnegie unit, a measurable, consistent unit to ensure that educational institutions followed some consistent framework in order to be called post-secondary university or college. This unit was defined by time in the year 1906. Yeah, things have changed. It was a time when some sort of standard was needed, and it was a time, and time was a thing we knew how to measure. We could measure time. That original metric was defined as the amount of time a student studies a subject with a teacher. Just think about that for a minute. Nothing about mastery, nothing about learning. In fact, The goal of this original metric was to measure how faculty engage as part of a larger goal to support faculty with a retirement option and a career path. Now, certainly, that's important and worthy, but it's not about learning. It was also a method for building university budgets. And I will come back to this notion of budgets as drivers in a few minutes. As long ago as the 1960s, this metric was being called into question as it has been used as a measure of the quality of learning when it was designed really only as a measure of a student's exposure to content. That does not measure learning. Clinical hours were conceived using the same flawed logic. Hours of time spent being exposed to clinical experience became a measure for everything from the quality of a nursing program, accreditation, to the requirements for individuals to sit for the licensure exam. Now, we all know the incredible variability of clinical hours as a measure. Students don't benefit from this definition, as once again, it says nothing about learning. In fact, I propose that it is the variability in clinical hours that ultimately helped us adopt and embrace simulation as a more relevant method to ensure basic clinical skills and even advanced competencies. Let me reiterate, simulation is a critical tool for developing and measuring advanced competencies. And thank God we're here now today, not gasping about that. As to the final part of this first sentence, grades, I have a lot to say about that. Grades, like GPA, are false measures. Oh, I heard an audible gasp. For many years, grades have been calculated using a norm referenced system, where the highest grade is the one that is the highest in a group of students, norm referencing, also called grading on the curve. Norm reference grading does not measure mastery, since the measurement is reflective of what the group knows, and in fact, the most knowledgeable person within the group sets the high standard, and a bell curve sets the norm. Grading on a curve means adjusting student scores after an assignment. The idea of the curve goes back to a bell curve, right? In a typical class, professors can expect the majority of grades to be here, the top of the bell curve, and that's where the class average is, and there's going to be a smaller number of A's over here and a smaller number of failing grades over here. So therefore, an A or a 4.0 grade can mean that the best person in the group knew 70% of the material and could easily show a C to be 30 to 40% of the material is known by the majority of students in the norming group. Grades are a statistical distribution of how a group of students perform on a given exam. And don't even get me started on GPA. GPA is the average of those grades. Thus, my favorite hashtag, hashtag GPA is fake news. Math doesn't get any fuzzier than that. This fuzzy math doesn't even consider the variability of the quality of the exam and what it purports to measure. Not every exam is well constructed. We know this. We know that many exams have built-in bias and do not actually measure learning. Norm grading is a form of bias. In so many ways, our traditional academic metrics are flawed, biased, and do not focus on student outcomes. Even the president of the Carnegie Foundation recognizes the flaws, and in 2022, he said, "It seems past time to think about how do you build a legitimately outcomes-based system." Let's examine the next part of the statement. A new, more fluid future of confident, competent, new graduate nurses at all levels of entry and practice. Now, not all confident people are competent. But there is a strong correlation between competence and confidence. Competence and confidence. 2 points to consider here. Confidence alone is not enough. In 1999, Dunning-Kruger identified a phenomena, the Dunning-Kruger phenomena, where those who are overconfident in their ability may not actually be the top performers, whereas those who believe they are average or even slightly below often demonstrate greater skill. They were describing something we see sometimes with our students who are overconfident but project a strong presence or charisma that can translate into a bias about their actual abilities. That is why the competence-confidence loop is a critical aspect of learning, particularly in clinical practice. If confidence is our belief we can do something, then competence is the ability to actually do the thing. And the confidence-competence loop, these two things are connected. It means if we believe we can do something, we'll actually take action to do it, which increases our competence, which then increases our confidence, which allows us to take more action. And it supports the idea of all levels of practice being intertwined in such a way that competence accelerates advancement. Now we come to the final part of the vision statement. Individuals who will feel prepared and will be prepared to persist in high-quality nursing practice across their careers. This is a fundamental part of our job as educators. It's not enough to prepare nurses to enter practice. We have to consider and take seriously what knowledge, skills, and abilities nurses will need to persist in high-quality practice across their careers. I would go a step further and say we cannot accept the current reality of nurses leaving practice after 3 years. Now, we can blame the practice environments. We can blame our politics. We can blame our healthcare delivery system, our higher ed system, economic and social demands. But this blaming weakens us as educators by diminishing our accountability. We need to cast our vision of competency and learning to include the kinds of realities our grads will face and consider the kinds of competencies that will arm them for the future. How do they protect their own personal vision of care and sustain joy in practice? These are parts of the necessary competencies we must define. I recently had a chance to collaborate on a column for JCEN with a physician friend of mine I've known for 40 years. He had a life-threatening experience, and he woke up in a trauma ICU, terrified, in pain, and fearful for his future. A nurse cared for him on one shift, and that nurse changed his life. I can't really describe what she did, but her approach to practice activated him to a level of positive engagement that accelerated his healing. She had a healing practice, a patient activation practice, a practice that was happy and brought her joy and satisfaction and made him laugh, while giving him a new skill of reframing his thoughts to make him think about his journey to health in new ways. We worked together to write a story about healing and what it was for him, but the story was really about that nurse and other nurses who have the competence of healing. And how do we break that down? How do we create those competency statements? I submit to you that as difficult as that may be, and it may sound very difficult, that's our challenge in addressing persistence in high-quality practice across a career. Competency-based education focuses on the endpoint. It relies on well-articulated, measurable descriptions of the desired competencies and recognizes that not all learners come with the same abilities and not all learners have the same learning pace in learning different things. Unlike the mechanized models of the past where learning was measured by what could be achieved within a specific time frame, CBE considers that competency is the standard and the time it takes is the learner variable. That concept reframes how we think about teaching and learning, and it considers a level of individual support that has to be built into systems that currently may not exist. It means that instead of building mounds of curriculum, reading, lectures, and the like, we need to be so clear with our competencies and how they will be assessed that learners will have full transparency and accountability for their own outcomes. No more, will this be on the test moments. Because what it means to prove competency is apparent and available to all learners. Multiple assessments will be needed. The learning is in the process of mastery, not mastery itself. Assessments are as critical as competencies, and they must be aligned and developed concurrently. It's truly the growth mindset of learning that has eluded us for so long. Where systems like academic calendar and set testing timeframes and standardized methods of the past have actually undermined the complexity, individuality, and exquisite beauty of learning. In CBE, in its highest and best form, it holds the learner at the center of all decisions. It means that the decisions about how learners are treated, tested, communicated with, advanced, evaluated, literally all decisions related to the learner journey and actual learning are the first thing that is considered. The structures of the organization must be redesigned with the learner in mind if we are able to fully transform higher education to meet the needs of contemporary society. Being student or learner-centered isn't a new concept, but it hasn't truly been the central focus in higher ed. Like in healthcare, in this nation, where patient-centered care is often cited as a feature, it is secondary to finances, market share, and new technology. Our colleagues in healthcare are not making all decisions first and foremost based on how to heal and advance the health and wellness of our communities. It's a great goal. We all believe in it. But sad to say, this goal is secondary to ensuring the financial health of the organization first. Yes, I do understand, no money, no mission, I've heard it. But does that mean intrinsically that we cannot provide high-quality, safe, patient-centered health and health care without making finances our first decision point? I don't believe it. Just because that is the current standard operating procedure doesn't mean it is patient-centered or that it cannot become something more focused on healing, health, and wellness. By the way, I don't offer this generalization without consideration of some innovative practice sites that are actually trying to change this dynamic, but sadly, they're not the norm. Now let's apply the same scrutiny to our area, nursing education. If our primary goal is to educate nurses who are competent, confident, reflective of the diverse communities nurses serve, and will facilitate healing in a lifelong career, what might we do differently? If we are turning away qualified applicants, if learners are not completing their programs, including being dropped, or are leaving nursing practice altogether within 3 years of graduation, do we think that's okay? No. Maybe it's not possible to change every structure in your organization, but what can you change? If you agree that some of the outcomes we've delivered need to be better, what barriers do you see in your own systems that can be changed? Are you ready to interrogate your learning environment to see what doesn't primarily support learning and learners, and begin the work to reform those things? CBE provides a new framework for measuring learning, measuring not time, but competency. If you could make nursing education available to more people who are perhaps not currently present in your learner demographics, what would it take to do that? What if a learner's advancement from course to course was more fluidly defined by competencies rather than semester hours? Can you think of ways to do this? There are ways. What if learner assessments weren't one and done? We know mastery requires repetition. Not practice makes perfect, but perfect practice makes perfect. How can we expose learners to more ways to practice and master competencies? To be clear, I'm not only talking about skills here. I'm talking about complex competencies that include high executive functions like advocacy, family intervention, clinical detection and prediction, interprofessional collaboration, and healing. And maybe you can't see immediate ways to build CBE into your program, so a different kind of creativity could be required. In fact, creativity requires limits to fulfill its full potential. I know that sounds counterintuitive, but it is through limits that creativity flourishes. Picasso said, "Art is the elimination of the unnecessary." So creativity can and does thrive under constriction. But the good news is it can be great fun and deeply satisfying. And as Maya Angelou has said, you can't use up creativity. The more you use, the more you have. So maybe you work in new ways with other schools and programs to leverage strengths and weaknesses in pressing forward on your CBE journey. Maybe you seek and use vendors differently. Maybe you barter with other partners to use what they have in exchange for what you have. Maybe you collaborate within your own faculty groups in the development of competencies and assessments in ways you've not done before. Maybe you use the enhanced learner activation that CBE can offer to use learner design ideas for achieving mastery. CBE is a strong framework for learning, but its future success will come from the creativity of faculty who look at learning through a new lens, seeing possibilities and exciting new futures. So as we face this challenge, the challenge to transform learning and teaching with some intrepidation, as with all change, we have to abandon some ways of thinking and doing to allow for new ones. While CBE will require us to learn new things and consider doing things differently, I believe all of us in nursing education share key beliefs that will become essential tools for our change journey. Here is what I believe nurse educators know, and having these things to guide us will make our journey better. We know that all students do not learn in the same way or even on the same schedule. We know that ability and capability to learn is present in thousands of individuals who've not had access to the opportunity to learn nursing. We know that the executive level skills of clinical decision-making and healing activation are at the very top of our learners' abilities, but skills learned along the way, growing and achieving along a learning pathway, build confidence and competence, and that is learner activation. We know that culturally diverse learner groups help teach each other nuances of individuality and shine lights on implicit bias. We know that competence in social and emotional aspects of nursing practice bring improved patient outcomes and enhance joy in the human interaction that is nursing. We know that competence and its associated camaraderie propagate joy and success in practice, which are key ingredients for a fulfilling and long-lasting career. We know that if we collaborate with our practice partners to develop the descriptions of essential competencies, we can develop new nurses who will have those competencies. We know that as we hone our abilities as educators to envision, design, and communicate the essential competencies of nursing practice, our learners will thrive and succeed. We know that our camaraderie with each other and our shared vision for nursing education enhances our own practice joy, our ability to guide change, and strengthen our commitment to better nursing education. We're all going to do that this week. We know that we can change the direction of health disparities in this country through our work as nursing educators. We know that facilitating learning is one of the highest callings, and the privilege of developing new nurses is our greatest treasure. We know that the future of nursing education reform and transformation is in our hands. And in its future state, diverse learners will thrive, nursing faculty will realize satisfaction in their roles as learning facilitators, employers will embrace and appreciate their new nursing workforce, and patients will benefit from nurse competency, advocacy, and compassionate care. I believe CBE can provide you all with an exciting new framework for your innovations in learning. The NLN strategic vision for CBE details how it differs from traditional academic learning models and describes its key features. There is structure to it that is not equivocal. But as we've discussed here today, structure can actually generate and stimulate creativity. Over the next few days, as you attend your meetings, one or some of you may step to the mic and present an idea that generates audible gasps. Will you listen? Will you stay curious? Will you be ready to set aside what you are comfortable with and ask, could this help my learners? I told you what I think nurse educators know, and in that list is the thread of innovation and creativity that resides in each of you. Thank you.
I've known Dr. Jan Jones-Schenk for several decades, and when you know someone for a long, we were babes. When you know someone for a long time, you forget how brilliant they are. I mean, they're just your friend, and so you kind of downplay their brilliance. In fact, you may forget it. And today she reminded me of the incredible gift that she brings to nursing and to healthcare, and how she can break it down in bite-sized pieces for those of us who can't take the big pieces all at once. Thank you, Dr. Jan Jones-Schenk, from your admirer and friend.
Thank you, my friend. Thank you for this privilege. What an honor. What an honor.